Hello, hello. Welcome back, everybody. Welcome back to Talking Teeth. We are here with Dr. Publio Silfa, expert in everything. We have another professor, Dr. Lokesh Rao, who's amazingly smart. I like to surround myself with smart people because I'm not that smart. But today we're here to talk a very, very prevalent topic of sleep apnea. You may have heard it as snoring or sleep apnea, obstruction, airway, all these different, titles that they give this. The bottom line is this: 83 million people, that's a lot of people, that have been diagnosed with sleep apnea suffer. Some of them are mild, some of them are moderate, and some of them are very severe. Now, if you're in the mild category, you may be snoring a little bit, that's okay, but definitely if you're thinking about it or your partner has told you, honey, you're snoring. And it's men and women. It's not just men. Mostly men. But it's a lot of men. A lot of women too. So if anybody said that to you, it's a good idea to get a sleep study. A lot of the insurance pay for it. It's a really good way just to know where you are. Mild, moderate, severe. We're going to be talking in depth about it, different ways to heal it, what it does to your body. If you're experiencing this and those of you who have it, you know what it can do. Basically, at the end of that day, when you're sleeping and you're stop breathing for 3 seconds or 5 seconds or 10 seconds, there's a lack of oxygen going to your brain, lack of oxygen going to your heart, lack of oxygen going to your body, and sometimes you wake up. That's why when people sleep or they snore, they constantly wake up. The body never gets what we call REM, deep sleep. This is what you're supposed to do. When you work hard at your job, you're working all day, you need to rest. If you're not getting rest, your brain can't rest, then you're not going to be performing really well, which causes you to have a hyperactive system that needs more food to stay alive. You know what happens then? You're eating more. So this is a roundabout type of disease. It's a quiet disease, and nobody's talking about it until now. Last 10 years, a lot of discussions about it, and a lot of quote-unquote experts on sleep apnea. But I must tell you, the real experts have been doing this for 25 years.
Yeah.
Publio.
Well, in my case, I see that 3 out of 10 patients that walk into the office have some sort of sleep apnea. And the signs, they show it with cardiovascular disease, with brain fog, with cardiovascular disease in the way that they're getting the obesity, they're starting to get diagnosed with diabetes. So all these common factors have that correlation with the sleep apnea. And it's just prevalent.
And here are the risks. Ready? And you can look this up in Google or any AI program. But basically, you got high blood pressure that is caused by sleep apnea. On top of all the other conditions that you may have, right? If you're not exercising, you're going to have high blood pressure. Heart disease, stroke, diabetes 2, these are all manifestations of sleep apnea. What have you seen in your practice?
I've seen, as far as systemic manifestations, I've seen people with extensive uncontrolled type 2 diabetes, weight gain, the excessive heart problems such as more arrhythmias, high blood pressure, a higher incidence of cardiac arrest, stroke.
And a lot of it has to do with also, you see the patients who have, or people who have daytime fatigue. Daytime fatigue, if there's loud snoring. I see some of my friends, sometimes we're watching a movie and all of a sudden they just kind of fall asleep because they're so tired, and then they start snoring. Now, what I've seen in my life and myself, when I'm sleeping straight up and down backwards, you're going to find me a little bit snoring or some kind of noise that I'm making. But I find when people are on their side or on the left side, right side, they're not snoring as much because they can breathe a little bit better. By the way, there are tests, not only sleep tests, to understand what kind of level that you have, but here at the New York Smile Institute, we have a special high-tech CAT scan machine that gives us the airway, and we'll show it to you. That actually gives us a quantifiable number. The number of range that we have on our CT scan is 0 to 300. 300 being a nice wide airway space, and anything under 100, it actually shows up black or red. And now we can tell patients, hey, you already have an anatomical condition. And now at least we know they have an anatomical condition. Now they may also have the sleep apnea on top of it.
Can you describe to the public, because we could understand what is obstruction of that airway, what does it look like a regular airway? What does it look to be obstructed? How wide is that?
So when we take the CBCT scan, the patient's standing up. So we have a kind of like a standard position when they're taking it. What basically it looks like on a 300 scale would be a high scale. It's about an inch wide, standing up. Now, what happens when you go to sleep?
Gravity.
Gravity, your tongue goes back, your throat goes back.
And that airway just
even if you have a 300 airway, it starts getting collapsed. I want to bring it to everybody's attention because this is the easiest way to remember it. When you have a McDonald's, everybody's been to McDonald's or Burger King, the straw, that straw is about 1 centimeter in diameter. And you know you have a coffee straw? Here it is, right here. This coffee straw is about 4 millimeters wide in diameter. You can't breathe from a 4 millimeter straw, but from a 1 centimeter straw, you can breathe. And that's the difference. And this is what it sounds like. I'm sorry to be graphic about it, but when you have sleep apnea, it sounds like this. All right, it's closed. It's collapsed on top of the soft palate and the tongue. Whereas when you get the sleep appliances, when you get the CPAP, you get these other machines, we'll talk about the different appliances, all of a sudden you hear, they're still not open freely, but they can breathe. And that's the difference. We're talking about a 4 millimeter difference of getting the tongue out forward, which is what these appliances do. They bring your jaw forward so that the tongue follows and just opens up that airway just a little bit to allow you to breathe. But talk about that.
You know, so I've had several cases of diagnosed cases that I've referred to the specialist. But I had one case specific that comes to mind, and it was that after the treatment was done, the daughter comes to me and says, "You saved my mom and my dad's marriage." I'm like, "What are you talking about? I just did a sleep appliance to create the intraoral appliance for them and get them to where they need to do." No, you don't understand. My dad has been working for years, and all he slept every night was 2 to 3 hours interrupted because he would not breathe for like 30, 40 seconds and wake up into a panic where his body was fighting and fighting overnight to breathe.
Right.
So what you gave him back was that oxygen, that blood flow. He lost the weight. He started to have more conversation. He wasn't tired and grumpy, and we never understood why. And I'm like, wow, I didn't realize that a simple change in giving the opportunity to breathe, breathe and sleep, because sleep is a superpower, changed someone's life. That was my mind.
There's a lot of couples that I talk to in the operatory. They sleep in different beds, different rooms. They can't handle it. Women and men snoring. It's a problem, especially for a marriage. You know, you want to be close to your partner. You want to be together. And if that was waking you up, it's a problem.
Yes, but not only the waking up problem. It was that he was grumpy all day because he wasn't getting the sleep.
When you don't have oxygen,
getting the rest.
Your brain is in a different mind frame. You can't think. You start eating more. You're falling asleep during the day at Zoom meetings. I've seen people fall asleep on a Zoom meeting. You know, they can't stay awake. When you have breathing and your oxygen is in your brain and you're working out and you're exercising, you get much, much better sleep. Any comment on that, Dr. Locke?
Absolutely. I personally got tired of sleeping on the couch. My wife kicked me out of the bed because I was snoring. And
how about when they leave?
I mean, it is a comfortable couch, mind you.
And they walk away. They're like, "Yeah, okay, leave him there.
Leave him there."
But no, I was snoring pretty loudly. My kids even told me about it, and so I tried to do something about it. And I've had patients that had the mandibular advancement devices. I've had patients that have had CPAPs, family too. And I've heard their complaints. I've looked into it, and I decided to try a tongue stabilizing device.
Okay.
Yeah.
And it basically looks like an inverted pacifier. It looks goofy, but it helped me out and got me back in the bedroom.
Let's talk about...
And which is interesting, You don't need to be obese. You don't need to have diabetes to have
happen
the
to anyone.
airway obstruction. In your case, you were the undiagnosed population, which is almost 80% of the population.
Yeah, let's talk about treatment. So for the severe patients, we're talking about the severe patients, severe apnea. A lot of patients are on what's called a CPAP machine. It's a customized airflow machine. It's really loud, it's really uncomfortable, and the partner is definitely not around when you're using it. So a lot of our patients have been going to our specialist here at the New York Smile Institute. His name is Dr. Jay Newhouse. He's been doing sleep apnea for 27 years. He didn't just start it. He's been doing it for a long, long time. He's seen the changes in the appliances, and he's always up to speed of what kind of appliance. We use the Panthera, but there's other types of appliances. But basically, what the appliance is doing is patients are wearing it at night. They're getting off the CPAP machine, and the appliance is bringing, like we said, the jaw forward to open up the airway. Tell us the different types of appliances that are available.
Well,
you got Pro Somnus, you got Panthera,
Mm-hmm.
you got Somodent,
You got
and
the
you got
tap
Thornton
device.
and the tap machine.
Mm-hmm.
So again, he's used to use the Somno, and he's used to use the Pro Somnus. He's using the Panthera. That's what he, uses now, and he's very comfortable with it. How does that work? How did they get the appliance?
Well, they start by doing the intraoral scan
Right.
of the mouth. Now we have digital technology. We get the bite. We don't have to take multiple impressions. But there's also a process where they look at the CT scan,
Right.
and they see how much the appliance needs to be open or expanded in order to create that proper
Right.
expansion of the mandible. And by tweaking this and taking the CT scan, they're measuring if there is improvement in that airway opening, and that's when it comes into play.
I urge everybody to get a sleep study first. A lot of the sleep studies right now, you can hold it in your pocket, you sleep one night, and they track the airway and how many times you're waking up, which is very, very dramatic. When you see that you're waking up 20, 30, 40 times a night, it tells you, hey, we have to do something. And again, it's also the whether it's mild, moderate, or severe. Once you have that information, we could take a CBCT scan, see where you are in terms of obstruction.
Mm-hmm.
I've even seen patients, they're not overweight or anything. They're perfectly good, healthy individuals, but their airway is still collapsed just by, like you. Look, nice
Absolutely.
skinny guy. And yet you still have it. So it's not only for people who are overweight. That's, I think, a byproduct sometimes of it. And remember, 25 years ago, we didn't know about this. So they used to say, oh, your diet's got to change, or you have to exercise more. Oh, we got to do some heart medication. When in reality, it was sleep the whole time.
Treating the symptom and not the problem.
Treating the symptom. The symptom is snoring. Snoring is the symptom. Sleep apnea is the condition, and then the clinical manifestations.
Side effects and the manifestations.
The clinical manifestations are
obesity, diabetes,
Exactly.
Chronic heart failure,
Stroke.
Stroke is, what happens with the stroke, just so everybody understands what a stroke is. When you don't have oxygen in your blood, the cells in your brain get dehydrated, and sometimes they pop. Or there's a blood clot because there's no oxygen. You actually need oxygen in the blood to keep the blood flowing. So when there's a decrease in blood flow and a decrease in oxygen, you start getting small little clots. Now, usually little clots last for about 20 or 30 minutes, and the body gets rid of them because you have natural heparin in your natural blood. But when that oxygen gets deprived, especially at night when you're sleeping, and a lot of patients, I listen to a lot of my patients' clinical symptoms of when they come in and said, oh, my husband had a stroke. And I'll say, what time did he have the stroke? And I can tell you 90% of the time, it's in the morning. Why? Because they were sleeping, they had sleep apnea, they wake up, their body starts getting up, there's a little clot that's running around during the nighttime, they get up, 9 o'clock, 10 o'clock, they have a stroke. Ask your friends if they're having strokes in the morning time, it probably has to do with sleep apnea. I think there's a correlation there. Questions?
No.
Sorry.
Is this a procedure that usually covered through medical insurance? Because that's the big question I usually get asked.
Yeah, the big question about paying for all this is Dr. Jay Newhouse has figured out the medical part of it so that the medical insurance pays for it, and now the medical insurance are paying much more for it, so it's definitely going to be covered under your medical insurance. Sometimes they don't cover the sleep study, and they cover the appliance once they have a record of the sleep study. Some insurances cover both, and some insurances only cover the sleep study and don't cover the appliance. So out of pocket, if it's no insurance, it's in the range of $9,000. But he's finding 90% of the patients are being covered by their medical insurance. So it's a really good news for people who have insurance.
And I mean, the most common question, because patients, when they start wearing a night guard is for life. How long should the appliance be used on a patient?
How long should the appliance be used on a patient? We have an answer for that? Is it forever? It's forever. The answer is forever from the expert over here. The appliance needs to be used. Once you start using it, it's going to add mandibular advance your jaw, and you need to wear it. You can't stop wearing it. Is that correct? Okay.
Quick question. When you have a device like that that's pulling your mandible or your lower jaw forward, you're sleeping for about anywhere from 6, 8, 10 hours with your jaw in an awkward position, a position that it's not normally used to. Is there anything to do in the morning to try to get the jaw back into place? Because
I haven't seen problems with the patients post evening or after the night in terms of the muscles hurting or anything, because they're just being kind of moved forward. What I have seen, some of the drawbacks, because you got to know about this, sometimes if your dentist is not making the appliance correctly, or if you have defective crowns on your teeth, because basically the teeth are holding the guard. So if the crowns are defective, they'll come out. We have a lot of patients come from sleep apnea, said, I was doing my sleep, I'm sleeping great, but my crowns are falling out. So if the crowns are defective, or the patients have had some kind of braces or Invisalign, the teeth are constantly moving, then sometimes the appliance doesn't fit in. So that I've seen it be a problem. We have to re-cement some crowns because it's very tight. As you can see it here, the appliance is coming forward, moving the jaw forward, which is taking the tongue and moving it forward and allowing that 3 or 4 millimeter space to become just a little bit larger so the patient can breathe. But that's what it looks like. That's from Panthera.
Another thing to note.
Comments? Give me some questions.
Another thing to note is that when you wear one of these devices over this long period of time, your bite may be in an awkward position in the morning. So what your dentist or your sleep specialist may make for you is a little wafer that you can help reset your jaw back in the right occlusion of the right bite.
We recommend you see your dentist. We recommend you see a sleep apnea specialist. We recommend a CBCT scan to analyze the airway space, and definitely get a sleep study at night that you could take home. You don't have to go to any center to get a sleep study. But we find that, for me, I think it's 4 out of 10 patients have this problem, and 2 out of 10 have severe sleep apnea. So it's definitely prevalent. It's definitely something that we want to look at. And again, there's a lot of specialists now that can diagnose it. Talk about one of the questions was about the ENT and how the ENT are involved in all this.
Usually the ENT have the opportunity to work through the medical part faster, like processing, getting a medical clearance, and getting it approved. But on how advanced it is, I've seen the sleep study that they were able to have with the patient. Some of them, they have it with the facility they work with, so they have a more systemized approach to taking care of it.
Yeah, and there's also another functional issue. Some of the patients, a low percentage, about 12%, have physical obstruction of their soft palate. So if the soft palate is going too far down, sometimes surgical approach is necessary. So if they find that the sleep study is severe, they find that the airway is okay and not obstructed, but there's a physical deformity in the soft palate, sometimes they need surgery for that. And again, it's a life-saving type of surgery, so it's not like elective. You want to save your life, save your marriage, save your long-term health. You have to go through that surgery. But again, it's a small percentage of patients. Most patients can get rid of it with a sleep appliance, some kind of mandibular advancement. Any other points?
How do you decide which kind of appliance?
We only use this one.
Which one was that again?
Panthera.
Oh yes,
We only
Panthera.
use Panthera. Again,
There's
we
so
follow.
many out-
We follow the recommendation of our specialist. Right? He's been doing it for 27 years. So when Jay, he has used all of these, by the way. He has had experience with all of these. So when he said we have a new company, not because it was cheaper, not because it was faster, because he felt it was more effective, then we switched over to that. So again, as us, for clinicians, we ask the patient, we have a really quick sleep questionnaire. That's 1 page. And usually if they check more than 5 or 6 yes boxes, we're going to refer them to Dr. Jay Newhouse. He's going to do the sleep study at home. We're going to take a CBCT, figure out where the oral area is and how much breathing access they have. Then he does the impressions. I think it's about 2-week turnaround, and they get the appliance.
And these sleep appliances, they're only recommended for people with mild and moderate sleep apnea. Not
No.
for
There's people that have severe as well.
too?
Yeah, because there's people who have
Do we want to
CPAP.
just like hop in the hot chair and like ask these questions?
No, it's okay.
No, okay, all right.
Sleep. What happens is they have, even at severe patients who have CPAP, he's taken 50% of the CPAP patients off CPAP.
Okay.
Right, so the appliance works. If it didn't work, we wouldn't be doing this. But it really works. He knows what to do. He knows how to diagnose. He's very smart about it. And also, there's also follow-up. You need to have follow-up with these patients. You want to do a sleep study 3 months later and see it. There's a difference in the pattern of the oxygen. Maybe the sleep pattern needs to be tweaked a little bit more. So there's got to be also a post-op 2-3 months later to make sure, hey, you know what? You're breathing really well. This is going really well. Or you're still you went from 40 episodes to 10 episodes. So there has to be always a check back 6 months, 4 months later to figure out, has it helped the patient? Yeah. Good question.
There are also instances where the ENT will prescribe a CPAP for a patient, and the CPAP works, and if it doesn't work or they can't tolerate it, then they move on to the mandibular advancement device. And there are a small group of patients that need a combination of the two.
Right. Okay.
I have my face.
Yes.
My husband in a combination.
Wait, can you take
He's
Go ahead.
using, he was having a hard time with the CPAP, and he moved all around and everything. And I said, listen, let's do a combination therapy. Let's get you an oral appliance. So I got him on the Serena.
Okay.
He loves his CPAP now because his jaw is not going.
Right.
So it's
right.
the mask is staying in
Right,
place.
because that's what I hear
and
with the
he loves
CPAP.
it.
Even though you have this oxygen and air coming through you, your jaw is still back.
Exactly.
So it's like pushing air into a black hole you still can't get through. So by having the combination, at least you allow the air to get in.
Yeah, he loves it now.
Sleep is important. Ladies and gentlemen, sleep is important.
Sleep is a
6 to 8
superpower.
hours a day, minimum 6 to 8 hours a day. I hear people saying, oh, I only need 4 hours sleep. I only need 5 hours sleep. That catches up to you. It's not healthy. You got to sleep. The brain's got to relax. It's like a computer got to be shut off. You got to shut off. Take time for yourself. Get exercise. Breathe better. Look better. Smile better. Eat better. Feel better. Love better.
Love better.
And be happy. Enjoy your life. Thank you, everybody. We'll see you soon. Next episode.